Hello, my dear. I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. The topic of my lecture today is female sexual dysfunction key points. I have another full detailed lecture with the same title, Female Sexual Dysfunction, but today this is just key points. Try to know the updated knowledge within short time. Okay? Okay. Let us start with the first item here, which is the classification of female sexual dysfunction. Female sexual dysfunction include these 5 categories: female sexual interest and arousal disorder, female orgasmic disorder, genital pelvic pain and penetration disorder, dyspareunia, the old name, whether superficial or deep dyspareunia, or other penetration disorder, which is painful intercourse. Dyspareunia means painful intercourse, okay, or other penetration disorder. This is one category, genital pelvic pain and penetration disorder. The next is substance and medication induced sexual dysfunction, like selective serotonin reuptake inhibitor medications, antidepressant and others, okay. And the last group is other specified and unspecified disorder, which doesn't belong to the other categories, okay. Okay, so those are the categories included in classification of female sexual disorder. Okay, let us start with the female sexual interest and arousal disorder. What does it mean? An absence of or a decrease in 3 or more of the following for 6 months or more. Okay, so female to have sexual interest and arousal disorder, she must have 3 or more of these factors, and the duration should be 6 months or more. Okay, what are these factors? Absence or decrease in interest in sexual activity, initiation of sexual activity and responsiveness from the partner, excitement during almost all sexual activity, sexual or erotic fantasies or thoughts, genital or non-genital sensations during sexual activity, interest or arousal in response to internal or external sexual or erotic stimuli, whatever visual, verbal, or written. Okay, so to say or diagnose female sexual interest and arousal disorder, the female should have an absence or decrease in 3 or more of these points. Okay, and what is the duration? 6 months or more. Okay, what about the orgasmic disorder? It involves orgasm that is absent, markedly diminished in intensity, or markedly delayed in response to stimulation despite high level of subjective arousal. Okay, so to say there is female orgasmic disorder, this orgasm may be absent or markedly diminished in intensity or markedly delayed in response to stimulation despite high level of subjective arousal. Okay? Okay. What is the duration of this problem? Should be 6 months or more. Okay? Acquired orgasmic disorder are frequently related to new disorder, including psychological or behavioral disorder, or to anatomic changes, like women undergone surgery, genital surgery, or cancer, or treatment of cancer. Okay? So this is the as regard the female orgasmic disorder. Could be lifelong, could be acquired, and so on. Next is the genitopelvic pain and penetration disorder, like dyspareunia and other penetration disorder. Okay? It is characterized by the presence of one or more of the following symptoms for 6 months or more. Remember, all the time 6 months duration or more should be present. Okay? So we need one or more item of these to say genitopelvic pain and penetration disorder. What are the items? Deep pelvic pain and the tension during penetration or superficial burning vulvovaginal pain caused by slight touch. Okay? Or fear or anxiety before, during, or after penetration, which often leads to decreased sexual desire or avoidance of sexual activity. Okay? What else? Reflexive tightening of the vaginal muscles when the vaginal entry is attempted, making penetration difficult or impossible. What's called vaginismus in the old name vaginismus. Okay? So, reflective tightening of the vaginal muscles when vaginal entry is attempted, making penetration difficult or impossible. Okay? Okay. So, presence of one of these items or more for duration 6 months or more considered genitopelvic pain and penetration disorder. Okay? What is the etiology for female sexual dysfunction? Psychological and physical factors usually contribute to female sexual dysfunction. They may interact with each other, worsening dysfunction. Okay? For example, psychological factors, mood disorders, effects of past experiences, concerns about negative outcome, like fear of pregnancy and so on. The woman's specific circumstances, like low sexual self-image and distractions. Okay? What about the physical factor? Include genital conditions like vulvodynia, vulvitis, vaginitis, anomalies, systemic and hormonal factors, and drugs, particularly selective serotonin reuptake inhibitors. Okay? So what is the treatment? In short, as we have these three big categories, psychological therapy or medications, drugs, or pelvic floor physical therapy. This is the three big categories in treatment of female sexual dysfunction. Psychological therapy first start with interview to both partner separately and together if possible. Then incorporate psychological therapy. For example, cognitive behavioral therapy, mindfulness, combination of the two into treatment for most types of female sexual dysfunction. What about the drugs that can be given? Could be estrogen therapy, can be used to treat sexual dysfunction in women with genitourinary syndrome of postmenopausal age. Okay? Why? Because these atrophic changes in the vulva and the vagina can be treated with low dose vaginal estrogen like tablets, gel, cream, rings. Okay? Okay. What about androgen therapy? Can be considered also for postmenopausal women with sexual interest and arousal disorder. Transdermal testosterone, like dose of 300 microgram once daily, as in this picture. This is the transdermal patch. Okay, but testosterone level should be measured at baseline and after 3 to 6 weeks. And remember that short-term treatment is recommended. And also, you should monitor any side effects of androgen therapy like hirsutism and so on. Okay? Again, in drugs used for female sexual dysfunction, flibanserin, which is a serotonin receptor agonist and antagonist. It can be given in a dose of 100 milligram oral once daily at bedtime. It is used for premenopause women with hypoactive sexual desire disorder. However, in systematic review, the quality of evidence for effectiveness and the safety was graded low, and the beneficial effect was minimal. And you should know that flibanserin has black box warning stating that ingesting flibanserin and the alcohol close together or taking flibanserin with moderate or strong CYP3A4 inhibitor or having hepatic impairment increase the risk of hypotension and the syncope. Okay? So side effect of hypotension and syncope can happen especially in the presence of liver impairment or alcohol drinking. Okay? So you should know this side effect before prescribing this medication, and be sure that the patient will take it at bedtime, not at the morning when she's going to work, because hypotension may occur. Another drug, bupropion, which is a norepinephrine dopamine reuptake inhibitor. Some evidence suggests that women with sexual interest and arousal disorder due to use of selective serotonin reuptake inhibitor may benefit from adding bupropion. So, if I have a woman receiving drugs, antidepressant, selective serotonin reuptake inhibitor, okay, I can add, and has a problem with the sexual interest and arousal disorder, I can add bupropion to manage this problem. Why? Because bupropion is a norepinephrine dopamine reuptake inhibitor. Okay? So will improve the condition. Another drug is sildenafil. There is some evidence suggests that if women stop having orgasm when they started taking selective serotonin reuptake inhibitor, sildenafil may help them have orgasm again. Okay? So she lost the orgasm because she is taking drug selective serotonin reuptake inhibitor. So how to regain orgasm? There is some evidence that sildenafil can regain orgasm in such women. But you should know that this drug is not recommended yet for this purpose in routine practice. What about pelvic floor physical therapy? Really, pelvic floor physical therapy is a mainstay treatment of genital pelvic pain and penetration disorder. What is the aim of this therapy? Is to teach women to relax the pelvic floor and decrease reflex tightening. Pelvic floor physical therapy, including what? Including pelvic floor muscle training, soft tissue mobilization, trigger point pressure, myofascial release, electric stimulation, biofeedback, and therapeutic ultrasonography. And you should know that there is prescription devices available for self-dilatation in women with tight pelvic muscle, which contribute to dyspareunia, like this picture, smaller in size, increasing in size and weight, and the woman can use a smaller one by herself, trying to introduce inside the vagina slowly, then with time increase the diameter and so on. Okay, this is the last slide. This is my box, published on Amazon textbook of obstetric textbook, gynecology contraception handbook, and the multiple choice question book. And this is my site on Amazon as an user, and this is my site on YouTube channel. You can find many lectures updated in OB-GYN, and this is another scientific site on the blogspot. Okay, thank you everybody.